Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a geriatrician called Dr. Claire Cox giving a presentation on the subject of end-of-life care for people with dementia. You now have 90 seconds to read questions 31 to 36.
My name's Dr. Claire Cox. I'm a geriatrician specialising in palliative care. My topic today is an increasingly important issue: end-of-life care for dementia patients. The care of dementia patients presents certain problems. Dementia is a terminal illness and is the 3rd highest cause of death in Australia. Different from other such conditions, it has an unpredictable trajectory and there can be difficult issues around patients' mental capacity, decision-making and communication. But, in spite of an equal need for palliative care services, dementia patients don't always fit the traditional model of such care. Families often suffer distress because they feel unable to ensure that their loved one's wishes are being respected, or just don't know what that person wanted because the discussion wasn't held early enough. There is therefore a clear need for well-funded, patient-centred palliative dementia care that's available when and where it's needed. I do a lot of work with Dementia Australia, an organisation which represents the needs of Australians living with all types of dementia, and of their families and carers. It also campaigns on dementia issues and funds research. Dementia Australia decided it was the right time to examine the issue of end-of-life dementia care from the perspective of the consumer as well as from that of the healthcare professional. It's a timely initiative. We have plenty of anecdotal evidence but not enough hard facts about what's going wrong and why the system's failing. But the current situation isn't all bad. Despite the issues I've mentioned, I've heard some wonderful examples of how it has made a big difference to people's lives. Things can obviously go badly wrong if this isn't handled well. But in the right circumstances, people with dementia can reach the end of their lives peacefully and with dignity. Dementia Australia commissioned researchers to conduct a survey on the end-of-life issues affecting dementia patients. The survey covered both care professionals, that's doctors, nurses and others working with dementia patients, as well as family member carers. The interest was overwhelming with more than 1,000 responses from around Australia. But what do the results tell us? Well, the initial results confirmed what we've heard about access to appropriate end-of-life care. It was obvious immediately that there was a between the perceptions of care professionals and family member carers about end-of-life dementia care. For instance, while 58% of family member carers said that they didn't have access to palliative care specialists and 68% didn't have access to hospices, 3/4 of care professionals indicated that people with dementia in their area do in fact have access to palliative care. This begs the question of whether consumers, that is patients and family member carers, might not be aware of services that are available. Another notable finding of the survey was that care professionals often lack knowledge of the legal issues surrounding end-of-life care. Some reports indicate that care professionals are at times reluctant to use pain medications, such as morphine, because of concerns about hastening a patient's death. However, access to appropriate pain relief is considered to be a fundamental human right, even if death is earlier as a secondary effect of medication. Our survey found that 27% of care professionals were unsure about this, or didn't believe that patients are legally entitled to adequate pain control, if it might hasten death. So perhaps it isn't surprising then that a quarter of former family member carers felt that pain wasn't adequate. This lack of awareness extends beyond pain management. The statistics on refusing treatment were particular. Almost a third of care professionals were unaware that people have the right to refuse food and hydration, and 1 in 10 also thought refusal of antibiotics wasn't an option for patients in end-of-life care. How can we ever achieve consumer empowerment and consumer-directed care if the professionals are so ill-informed? There's a clear need for greater information and training on patients' rights. Yet over a third of care professionals said they hadn't received any such training at all. It's obvious that end-of-life care planning is desirable. Discussing and documenting preferences is clearly the best way of minimising the burden of decision-making on carers and ensuring patients' wishes are respected. Advanced care planning is essentially an insurance policy that helps to protect our patients in case they lose their decision-making capacity. Even though a patient might believe that loved ones will have their best interests at heart, the evidence shows that such people aren't that good at knowing what decisions those they love would make on complex matters such as infection control and hydration. So before I go on to...
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a hospital doctor called Dr. Keith Gardner giving a presentation about some research he's done on the subject of staff-patient communication. You now have 90 seconds to read questions 37 to 42.
Good morning. My name is Dr. Keith Gardner, and I'd like to talk to you today about some research I've been involved in concerning something that affects all health professionals, staff-patient communication. Now, firstly, let me reassure you that in feedback, patients seem positive about the way information is communicated to them. But I recently decided to explore the issue in more detail when I was in a hospital with a patient and witnessed for myself what can result when a healthcare professional assumes they've made themselves clear to a patient, when in fact they've been anything but. Luckily, I've had very few complaints made against members of my team, but the potential is certainly there. So first, let's start by looking at a typical hospital admission for an inpatient, and the first communication they have about any procedures they are to undergo. On arrival, a patient will complete necessary paperwork. Various staff will talk to them about their treatment during their stay, which is designed to reduce patient anxiety. However, from some patients' point of view, this interaction can seem very complex and difficult to take in, especially at a time when they're not at their best physically or mentally. So it's doubly important to check that any communication has been understood. Now, to illustrate what I'm talking about, let's take a hypothetical situation. I often use this because it highlights the potential consequences of poor communication. A man in his 80s is admitted to hospital, despite his protestations, with ongoing severe back pain. On investigation, it's found his cancer has spread. The outlook is poor, and further compounded by his becoming depressed and refusing to eat while in hospital. A feeding tube is inserted, a procedure which the patient complies with, but which his family members query. The doctor on duty updates them, assuming they're aware of the severity of the patient's condition, when in fact no such prognosis has been shared with them. An extreme case, but a plausible one, nevertheless. In order to find out exactly what inpatients felt about the service they were receiving in this hospital, we conducted a patient survey. The questions were carefully targeted to capture patients' opinions about the effectiveness of the communication they'd been involved in during their stay. The survey questioned patients on both what they had expected prior to admission and what their stay was really like. These two scores were then used to calculate what's called a GAP score. The survey also included questions to measure the patient's behavioral intention, that is, how willing they would be to return to the hospital for treatment. Patients completed the survey themselves, and results were then processed with the help of medical students. Now, the survey produced some interesting data about communication, including both praise and complaints. Clearly, in a hospital situation, staff are dealing with confidential and sensitive information, which must be communicated in private, a situation which can be difficult to achieve in a large and busy hospital. However, we scored highly on that point, and we were also pleased to note that staff did manage to communicate in a manner that treated patients with dignity and respect. Of course, staff also have to ensure patients fully understand what's been said to them, and this last point's where we received the most negative feedback. Both patients and relatives noted a tendency for professionals to resort to the use of jargon and complex terms when explaining both diagnoses and procedures, which left some patients confused. However, patients were generally satisfied with the information about any follow-up treatment provided after discharge. Also, once we'd sifted through all the results, a clear pattern began to emerge regarding the care given by nurses, which I found particularly interesting. I'd assumed that having a number of different nurses attending to a patient during their stay was a good thing, because you need enough staff to cover the various shifts and attend to patients' needs. What I certainly hadn't expected, though, was for patients to say they felt their recovery was faster when they had to communicate with only a small number of nurses. In other words, when they were surrounded by familiar faces. The findings aren't conclusive, and more investigative work needs to be done on a bigger sample, but it's certainly food for thought.
That is the end of Part C. You now have 2 minutes to check your answers.